from all over the world. After the successful Win India second annual conference held in Bangalore, organized by Win Karnataka team, which received abundant applause and appreciation for its exceptional organization and scientific content, Win India is adding another accolade to its portfolio with today's enlightening academic webinar. I'm the host of today's program, myself, Dr. Jyoti Priya. I'm consultant nephrologist working in MGM Muttur Medical Center, Pathanamthitta in Kerala. And I welcome you all to our monthly academic session. Today's Win India webinar will be a case-based academic session, and there will be two interesting cases, each on one on MGRS and other on vascular access crisis, and each case will be subsequently followed by an enlightening panel discussion. Now, without further ado, let's proceed to the various events of the day. First session is on the topic Eastern Experience in Rare Disease, MGRS. For that, I invite our speaker, Dr. Neeraj Saini, second year postgraduate resident, IPGMS, Kolkata. For moderating this session, may I invite Dr. Sonal Dalal, consultant nephrologist and transplant physician, director, Gujarat Kidney Foundation, Ahmedabad, Gujarat. She is also the head of Department of Nephrology, Sterling Hospital, Ahmedabad. Joining her will be Dr. Swarnalata Guditi, professor and head of nephrology, Nizam Institute of Medical Sciences, Hyderabad, Telangana. He is also the treasurer of Win India. We also have Dr. Maitri Shankar, assistant professor, Department of Nephrology, Institute of Nephrourology, Bangalore, and Dr. Preeti Meena, assistant professor of nephrology, AIMS, Bhubaneswar, as moderators of this session. I will request the moderators to take over the session. Over to you.
Thank you, Jyoti. Thank you for the introduction. Can we have the speaker, please? Today, Dr. Neeraj Saini is going to present a very interesting case of MGRS. Dr. Neeraj Saini, please. Siddharth, please share your slides.
Neeraj will start by saying that it's not a case, but a case series.
Yes. Yeah.
Good evening, all present. I'm sorry for the interruptions, please. Let's start. So today's topic is MGRS. It's a rare entity. It is monoclonal gammopathy of renal significance, right? Next slide. Next slide. The concept of the MGRS has actually it comes from MGUS, monoclonal gammopathy of unknown significance, and the concept was coined by the Robert Kiley in 1978. The risk of it is basically a pre-malignant state, and the risk of progression was very slow, less than 1% per year, and it increases with the age. Like in the general population below 50 years, it is 0.7%. And over the 50 years it's about 3.2%, and like over the 70 years it increases up to 5.3%. So IKMG coined the term MGRS, that is monoclonal gammopathy of renal significance, in 2012. So it is basically the MGUS only, but it is causing the renal damage, not the other organ damage. It is causing the renal damage. So still it is a benign therapy, is not required for MGUS, but MGRS, because it is causing the renal involvement and it has a potential to progress to ESRD to a varying degrees, it requires a treatment. Next slide. So initially, now the new definition includes the MGRS to include all the B and plasma cell clonal proliferative disorders. Initially, it was a dangerous small B cell clone, but now they say it's not just the B cell, it is B cell or the plasma cell having a monoclonal lymphoproliferative disorder. And it is not, there is no overt malignancy over there. There is no malignancy related complication. There is no myeloma defining events are there. But it is the only thing it is having is causing a renal involvement, not the other organ damage, not causing any malignancy related complication or a myeloma defining events. Next slide, please. So the updated definition of MGRS is any B cell or plasma cell clonal lymphoproliferative disorders having both of these characteristics. It is causing a kidney lesion which is related to a monoclonal immunoglobulin. and the underlying DNA plasma cell does not cause any tumor-related complication or doesn't meet any criteria for hematological criteria for a specific therapy. Next slide, please. So what among this hematological disorder, what we are referring to is where I have marked the stars: MGUS, smoldering multiple myeloma, smoldering Waldenström microglobulinemia, and monoclonal B-cell lymphocytosis. So these are the pre-malignant state which is not warranting for any malignancy-related therapy. The only thing it is causing in MGRS, they're coming under MGRS because their only end organ damage involved is a kidney and it has a potential to progress. So next slide, please. So why we are here to discuss about the MGRS? So, because it is a nephrotoxic monoclonal immunoglobulins which are being produced by the clone cells, right? So we need to address them. We need to give a proper as the IKMG has done, give a proper classification and the treatment for it, so that we can avoid the progression of the disease to end stage renal disease, as well as a proper protocol and as well as the therapy will direct us, and we can direct the government agencies to give the resources for the treatment for the same, and insurance awareness will be there. Second thing is the high rate of post-transplant reoccurrence. For example, PGNMID. There's a high rate of post-transplant reoccurrence of these MGRS disorders. So if the patient is going for transplant, we need to treat these disorders prior to transplant. And another thing is the potential to further involve the other organs, extra-renal organ involvement. So we want to avoid that as well. So we need to treat the underlying monoclonal disorders. Next slide, please. So talking about the multiple myeloma, as we know, it is an overt malignancy. These renal biopsy of this MGRS patient may share the same characters as with the we can found in the multiple myeloma. For example, primary amyloidosis patients in a case series, almost 8% of the patient having the AL amyloidosis in the biopsy has the evidence of overt multiple myeloma. This percentage is near about 60% in the monoclonal immunoglobulin deposition disease, mid PGNMID, it is almost 3%. And in fibrillar gene, it's less than 1%. Immunotoxoid glomerulopathy, it is 13%. And light chain proximal tubulopathy, it is 31%. Next slide, please. Next slide, please. Next slide. Yeah. So, approach to MGRS. First of all, a strong clinical suspicion is required. That is a very, very important thing. The clinical suspicion. We all should be aware of things and should be suspicious about when we have a high suspicion about this MGRS. It occurs mainly in the old age population. On an average, more than 50 years of age. And another thing which is the atypical course. This is the age when the patient is old and have a lot of comorbidities, diabetes, hypertension, and other diseases. So, like in patients having diabetes. So, if there's a typical course of the disease, more than 2 ml per meter square per year of fall of GFR is there. There's a proteinuria is there. Whenever there's no retinopathy in the eyes and other factors, active sediments is there in the urine. So whenever there's a typical course of a pre-existing renal disease, then also we should search for it. So, and another thing is basically the extra-renal involvement. Some of the MGRS disorders are associated with some extra-renal features. For example, the cryoglobulinemia. Cryoglobulinemia will have some kind of skin lesions. We know they may have the distal necrosis. They may have arthralgia. Similarly, in amyloidosis, patient may have a GI bleed. Patient may have the cardiac involvement. So there's some extra-renal involvement also. We should give attention to. Some patient having the light chain proximal tubulopathy, they may have the osteomalacia, like Fanconi syndrome-like presentation due to the urinary phosphate wasting. So the syndromic presentation of the MGRS can vary from acute renal failure. Acute renal failure, for example, cast nephropathy in multiple myeloma. They may have a nephrotic syndrome presentation along with the renal dysfunction that we commonly see in our case series as well. For example, in amyloidosis and monoclonal immunoglobulin deposition disease. And third, we can have a mixed nephrotic nephritic syndrome picture especially in the proliferative, the components having the proliferative component like PGNMID, C3GN, immunotactoid GN, and cryoglobulinemia, they have a mixed nephrotic nephritic syndrome like picture. Some may have a subnephrotic proteinuria with a progressive CKD. So this can be the syndromic presentation of the MGRS. Next slide, please. So once we have a clinical suspicion, strong clinical suspicion, our suspicion, then we'll go for the renal biopsy. The workup will start with a renal biopsy. We'll get a renal biopsy done. The renal biopsy will include as the light microscopy, immunofluorescence, electron microscopy as well, as it is not widely available. This is done in the certain cases. If we can have we can take help of some ancillary investigation modality as well. For example, the LM is suggestive of amyloidosis, but on the IF we are not getting any monoclonality. So what we can do, we can go for the laser microdissection. We can go thereafter the liquid chromatography and mass spectrometry for the other, for example, leg and other amyloidosis components. Then once we have this picture, renal biopsy, then we'll go for the detection of the monoclonal proteins in the serum and the urine, or the urine actually. Monoclonal protein, we'll get a serum protein electrophoresis, especially with the immunofixation. That is very important because it is a higher sensitivity than SPEP. Then UPEP. UPEP is basically done on the 24-hour urinary protein. The spot UPEP doesn't have so much of sensitivity. Then serum free light chain assay, individually, as well as the ratio. The ratio is generally between the 0.2 to 2.6, but in the renal dysfunctioning, it is 0.3 to 3.5. So it is a little bit increased in ratio. So that also, and one more important thing is the immunoglobulin, monoclonal immunoglobulin, which is a finding on the renal biopsy. The same monoclonal protein should match with the protein which is found in the serum, to prove that the same nephrotoxic monoclonal protein is causing the kidney injury. Then we will go for, thereafter we'll go for the finding out the underlying clonal population, whether it is a B cell, whether it is a lymphoplasmacytic cells, whether it is a plasma cells. So we get a bone marrow done. On bone marrow, we'll get a flow cytometry, we'll get a fish. We should get fish and flow cytometry at least to characterize the B cells, right? Whether it is a B cell, CD20 will be positive. On the plasma cell, CD19 and 45 will be aberrantly absent. So to characterize them, we should go for the bone marrow. We should always order bone marrow with flow cytometry or fish, whichever is available. Thereafter, we can identify the extrarenal manifestation. This extrarenal manifestation, which are visibly seen like skin and other, we can get it when once the patient come, we can identify them. And other, we can also evaluate. Like we have the amyloidosis, AL amyloidosis. Now we have to plan a treatment for the patient. So we will see the extrarenal organs being involved. We get an echocardiography done. We'll get a VNP done. We'll get an NCV EMG done to see whether other organs have been involved or not. Next slide, please. So,
Neeraj, we are already late. Proceed to the case series fast.
okay.
We will discuss all these in the panel discussion.
Okay, ma'am. Next slide, please. Next. Next, please.
Are you not going to show these biopsies?
I want to
With the
show.
biopsy.
Should I do it right now? Can panel
Yeah.
discuss?
You should do it right now. There is
Okay.
pathologist. Yeah.
Okay. So, just I want to show some slides. These are the just three cases out of my case series. So I'm taking the case number one. It was a 63-year-old male. He presented with the nephrotic syndrome. He had a nephrotic range proteinuria of 6 grams. Creatinine was 1.5. Serum free light chain ratio was low. It was 0.01. And the bone marrow examination suggested of 2% of plasma cells. Next slide. So, I'm showing the slides of the patient. First, I'm going to discuss the light microscopy. This is the H&E stain. what we can find out, we can see the 4 glomerulus here, right? There is no, I see the hypercellularity is not there. What we can see is basically these a cellular material deposition in the mesangial area or somewhere also in the capillary area. So what we can say overall, we can see on the this HNE stain, we are getting a nodular pattern of the glomerular injury. Now, what is the next step? Next step is to get the other stains done to get the characteristics of this nodular pattern of injury. So we can see this nodules are past negative, and on this on the silver stain, we can find out that this material nodules are silver negative. I'm not able to show the mesenteric stain here. I didn't got that slide from pathologist. So it was blue on the mesenteric stain. And this is the Congo red staining. We can see that there is a Congo positive. This material is Congo positive, right? Next slide. On the immunofluorescence, we can see there's a kappa is negative and lambda we can see up to the intensity of 3 positive. And this is exactly on the area of the mesangium, on the area of capillaries. And we can see here over the area of the perivascular lambda deposition is also there. So what we can, this nodular pattern of glomerular injury, which is past negative, silver negative, and blue on mesentericom, congruent positive with the lambda predominance, kappa negative, and other immunoglobulin and complement was also negative. So this points towards the amyloidosis, especially monoclonality will say as the AL amyloidosis. So this was one of the case from my series, and this patient is on basically receiving, I think, second dose of the 6th cycle of the Cybod regime. So next slide, please. So the second case was a 63-year-old male with the adult onset nephrotic syndrome. He was getting investigated somewhere outside in the 2019. He had a AONS presentation. The biopsy was done outside, which was suggested of immune complex mediated MPGN. The patient was given some steroid, which led to little improvement. Patient was lingering from 2019. He presented us in 2023, this year, with a shortness of breath and the pedal edema. He had a nephrotic range proteinuria of 5 gram, 3 plus proteinuria on dipstick. Renal dysfunction was there. Serum creatinine was 1.3. Kappa is to lambda ratio was within the normal range, but on immunofixation, as I said, it has a high sensitivity. We got a IgG band and lambda. Right. On bone marrow aspiration and biopsy, we got the 3% of the plasma cells. Next slide, please. Then we can, this is the light microscopic findings. This is a past in, as we can see. So what we can find out, we are seeing the 3 glomes here, right? In 3 glomes, we can see there some kind of cellularity is there. There's one segmental sclerosis, this in 11 o'clock here in this glomerulus. Rest there, we can see the cellularity is there. Where is the cellularity? This we can see in a mesangial area, right? And in the endocapillary area, because some of the capillary lumen seems to be obliterated. So these are both endocapillary and the mesangial hypercellularity, as well as the mesangial matrix expansion. What this hypercellularity giving an appearance is like a lobular accentuation, right? Lobular accentuation is there. We should see all the compartment. If we see the tubules, we can see the interstitial compartment. There's no back-to-back arrangement is lost somewhere. So on the silver, we're able to find whether it is edema or fibrosis. Next slide, please. So on the silver stain, we can see this lobular accentuation, as well as can we see this double contouring over here, right? We can see a lobular accentuation with the double contouring of the membrane. So it is an MPGN pattern of the injury which we are getting. And talking about the interstitium, there's a little bit of blackish over here. So there's the kind of interstitial fibrosis is also there. Next slide, please. Okay. On the immunofluorescence, we are getting IgG, C3, as well as a kappa. All these 3 are positive to the intensity of the 3 positive, and I may say, and the lambda is negative. So these MPGN pattern of injury anti-chain pattern of injury with this monoclonality with the kappa chain restriction, and we know PGNMID has a complete immunoglobulin being deposited, IgG, with the complement. We can get a low complement in this. We can get a low complement in other, like wherever the intact immunoglobulin get deposited, we get a low complement. We can get a low complement. For example, in the cryoglobulinemia, in the immunoductoid and PGNMID, where the IgG is being deposited, we can get that, and we are getting a light chain restriction. It is a kappa predominant. So this kind of injury is giving us the impression of PGNMID with the kappa predominance. Next slide, please. So case 3, this was a 59-year-old male with a hypertension with 24-hour urinary protein being subnephrotic 2.4 gram, serum creatinine of 3.44. SPEP positive, and we are not able to get the immunofixation for this patient, and bone marrow was plasma cell was 4%. Next slide, please. Next slide. Yeah. So his light microscopy, this is a pass. Can we see that the first of all, we can see the kind of injury. We are not silhouette seems to be normal, but there's some kind of mesangial matrix expansion giving the nodular appearance, right? Nodular appearance. Now, to get the characteristics of this nodular material, we have to see the other stains as well. Seeing the interstitium, we can see the TBM, the tubular basement membrane, is also prominent, right? And although they are good back-to-back arrangement. So next slide, let's see the this nodular injury pattern. Next slide. Yeah. So on next slide, we can see the material. Can we go to previous slide? So this nodular material, at least at the pass, it is pass positive, right? Next slide. Okay. On the silver, this is silver positive. We can see it's a silver positive. And mesenteric, it is blue. I couldn't show the Congo red here. Congo red is negative. Congo red was negative in this patient. So this kind of this nodules are pass positive, silver positive, blue on mesenteric. Next slide. And Congo negative. Congo negative. Next slide. On the immunofluorescence, we are getting the kappa positivity and lambda negativity, and kappa into the at least 3 positive, we can say. And the kappa is not only deposited within the this glomerulus and the mesangial material, it is also getting deposited over here as well. We can see the tubule borders. It is getting on the TBM as well. So this kind of injury, the nodular injury, glomerular injury, which is pass positive, silver positive, and blue on mesenteric, Congo red negative, with the monoclonality, because pass positive, silver positive, this can also be in the diabetic patient. We need to differentiate. Very close DT will be the diabetic nephropathy, but there the this monoclonality won't be there, right? And this we can get IgG can be deposited, but it will be lesser intensity. But monoclonality won't be there in the diabetic nephropathy. Next slide, please. Okay, coming to the AL amyloidosis, as I said, we have to assess the other organs before starting the treatment. We have to see the other organs involvement. For example, we'll check the cardiac status of the patient, as amyloidosis is a systemic disease. So we'll get a TROP-T and pro-BNP, echocardiography, ECG. For liver, we'll see the alkaline phosphatase level, whether it is more than 1.5 times of normal. Liver span, we will see whether it is more than 15 centimeter. Then coagulation system by PT, INR, APTT. And neuropathy, we'll get an NCV EMG for this patient. We will classically get the symmetric lower extremity sensory motor peripheral neuropathy. Or gastric, even the autonomic system is involved. We can get a gastric emptying disorders. We can get a pseudo obstruction. We can get a voiding dysfunction. Next slide, please. So coming to our data, we are MGRS series of our institute. Next slide. Next slide, please. Oh, the slides is not Hello, can you? Right. So baseline characteristics of our patient, there were the 22 patients. The age was ranging between the 31 to 74. The median age was 56, older age group. And there were more of male, the 15 male and 7 were female. Prevailing comorbidities, 12 patient has the comorbidities. As I said, these are the older age population having more comorbidities coexisting. So what comorbidity we got is 7 patient had the hypertension. This was prior, they were on treatment, and hypothyroidism in 4 and diabetic on the 4 patients. Next slide, please. Clinical presentation. 52, the maximum number of our patients, 52% of the patient had the ANS presentation, followed by end-stage renal disease in 17% of the patient, followed by infections. They suffer recurrent infections. Sometimes the old age person coming with a recurrent UTI, and they have some kind of this plasma cell dysplasia underlying. They have repeated infections, and thereafter we have the patient having the disproportionate anemia requiring the multiple blood transfusion, and 9% has the RPR representation. So among the staging, we have the maximum number of patients in the G5 stage, and 5 patients were in the G3B stage. 3 patients were in G2, G3A, and G4 stage, and only 1 patient was there in the G1 stage. Next slide. Renal biopsy profile. So all the 22 patients underwent the renal biopsy. There was no peri-procedural complications, right? We had the 13 patients who had amyloidosis on the renal biopsy, and out of them, 12 has the lambda predominance. Followed by we have the PGNMID. 7 patient with PGNMID, 5 patient has IgG and kappa, 1 patient has IgM, IgG and kappa, 1 patient has IgG and lambda. Thereafter, we got 2 patients with the light chain deposition disease, and both of them were having kappa predominance. Next slide. So praeaperitonemia profile, M band was seen in 10 out of 22 patients, about 45% of the patients. Free light chain ratio was altered in 20 out of 22 patients. It was 90.9. Sometimes we say when we have a strong clinical suspicion, the free light chain assay is very good screening test. We can get it prior to be very sure about going for a biopsy of these patient having a renal dysfunction, more looking like to be CKD, borderline kidney. So before going for the biopsy, this free light chain assays can also be considered a good screening test. In 90.9% of the patient has a deranged free light chain ratio. Beta 2 microglobulin, we are able to get it done in 9 patients. In all of them, it was elevated, ranging in the 7,000 to 28,000. Next slide, please. Clone detection. All of the patients underwent the bone marrow aspiration and biopsy. Plasma cells in all of them were less than 10%, and it was ranging between 2 to 9%. PET scan was done in 5 patients, and there was no plasmacytoma can be detected in them. Upper GI endoscopy was done in 7 patients, and the findings were normal. NT-proBNP was done in 10 patients out of 22, and most of them has the NT-proBNP more than 800. Next slide, please. Survival and follow-up. So in amyloidosis, we have the 7 patients are surviving, and 6 has expired. So among the 7 patients who are surviving, 5 are in the follow-up. 1 patient has received 12 cycles of Cybod. We have given this 12 cycle. After that, there was a normalization of the FLC ratio. This patient is getting his bone marrow transplantation done in the hematology department. He has recently been admitted for that. 1 patient has received 6 cycles with the normalization of FLC ratio. She's in the CKD stage 3B. Thereafter, she decided she has not given consent. She did not want to go for bone marrow transplantation. She's maintaining her. We are following her. FLC ratio is normal. 3 patients are undergoing right now undergoing the treatment. 1 patient has received 2 cycles, and 2 has received 1 cycles. One patient refused the treatment. It's very important, because as we are treating with most of them are elderly patients, so the consent for the treatment is also very important. So one refused the treatment. One patient has been transformed to myeloma, and this is being treated by the hematology department. Among those who expired, they three expired in the hospital, and the cause were infection and sepsis, and four of them, as I told, the infections are very common, and two patients died with the cardiac event. The PGNMID patients, one patient has the is on hemodialysis. One received only 2 cycles. Thereafter, he discontinued the treatment because he doesn't want to go for bone marrow transplantation, and he was already dialysis dependent. One patient was not offered because of his performance status being low. He has an ECOG performance score of 4. That is also very important. The quality of life of the old age patient have been diagnosed. We have to offer the treatment or not. So, as his performance status was poor, he was not offered the treatment, and 2 were lost to follow up. 2 patients expired, one due to sepsis and one due to cardiac event. Next slide, please. Among the light chain deposition disease, one patient has completed the 6 cycles. The last cycle she received actually on the May 2022. Till now, and she SFLC is normalized. Her creatinine is 0.96 milligram per deciliter right now. She presented with a creatinine of 2 to 3 somewhere, and her proteinuria right now is 152 milligram per 24 hour, and presently she is just on the ARBs, and we are monitoring her with the FLC ratio. One patient who did not receive the therapy, he is lost to follow up. Next slide, please. The therapy profile among the have 13 patients of amyloidosis. We are able to offer the treatment to 5 patients. The treatment profile was Cybor, that is cyclophosphamide, bortezomib, and Dexa. These are the cycles which has been received by the 2 patients received 1 cycle, 3 received 2, 1 patient received 3 cycles. Till now, they are undergoing the treatment. 1 has received 4. This patient, one who has received 6 cycles, has refused transplantation, but FLC is normalized. And this one, which is undergoing, the one who has received 12 cycles, is undergoing the bone marrow transplantation. So FLC is normalized in 2, and rest is undergoing the treatment. EGNMID, out of 7, we are able to offer treatment in 2. One has received 1 cycle and one has received 2 cycle. FLC is not being normalized yet. Light chain deposition disease, we have 2 patients. One was lost to follow. We are offering treatment to 1. Offered the treatment to 1. The Cybor was a treatment regime, and she has achieved a normalization of FLC, and she is presently just on ARBs, as I told. Next slide, please. 2 exceptional cases we got. We actually 2 patients, one presented with AKI and another presented with RPRF. The renal biopsy was suggested of light chain cast nephropathy. So as we know, this light chain cast nephropathy we consider as a myeloma defining event. But when we did a bone marrow, we have done that bone marrow, and it is the plasma cell percentage was less than 10%. So among the other myeloma defining event, CRAB, leaving apart the renal dysfunction, hypercalcemia, anemia, and bone survey, lytic lesions, all of them were absent. So the things came whether it is the MGRS or whether it is the impending multiple myeloma, he will progress to multiple myeloma in future. We offered the treatment to one of them. One did not receive his loss to follow. One patient has received the 6 cycles and he is doing fine now, and FLC is normalized. So this is a situation which we get in 2 patients. Next slide, please. So, summary till now is amyloidosis is a commonest MGRS. It may be present even in the younger age group, less than 50 year, having the monoclonal gammopathy, having the renal dysfunctioning. On evaluation came out to be amyloidosis. So they have they had a tendency to progress to CKD. So we need to offer the treatment to them. For deeper remission of the disease, we may need a stem cell transplantation in the younger population. Treatment related mortality, as I showed my survival data, like 30-40%, almost 20 to 30% patient has died because of the sepsis, some because of the arrhythmias, and some having a poor performance score. So we have to consider the treatment related mortality before offering the treatment to them. Not all the patient, but when we are sitting in a tertiary care center, we get the candidates who are appropriate for the stem cell transplantation, and we just need to have a conversant with this procedure, and we need to build a good relationship and very frequent relationship with the between us being nephrologist and the hemato-oncologist. Next. Uh, thank you everyone. That's all about my case series.
Yeah, thank you, Neeraja. I think it was a wonderful data, and you have a collection of 22 patients with a varied presentation. As
Yes,
you have
ma'am.
emphasized, so I think, because of the varied presentation, we often miss this, and we are seeing that, in our day-to-day practices, we are seeing more number of patients coming with MGRS. So, and of course, elderly patient, we should have very high suspicious and to get a diagnosis, particularly with all DPGNs and MPGN pattern, we often label it as, because all these patients also will have some amount of infection. So we often end up, labeling it as IRGN, and we often miss the diagnosis. So I think we should have very high suspicious because of considering the varied presentation, particularly in elderly patients, and then identifying them in the right time, and when treating the appropriate therapy will make a difference. The one thing I wanted to ask is, like, when you have shown that, different differential involvement is there. The patient have amyloid, significant number of patients, and then we have patient had a MIDD, and then tubuloopathy also, you said there was one patient. So, like, how was the outcomes? Was there any difference in the outcome of these patients? And the second thing is, now, as into transplantation also, our future would be to look at, as you said, as she has rightly emphasized, multidisciplinary approach, particularly with respect to the hematologist and then their medical oncologist, going into bone marrow transplant, stem cell transplant, as well as the kidney transplant, because most of these patients end up in having ESKD. So we should also look at the stem cell along with the kidney transplantation patients. Thank you. Over to the other chairpersons, please, for their comments.
Thank you, Dr. Neeraj. That was really an interesting case series of 22 cases. I just wanted to know, like, you gave 6 cycles for all the patients, or you were monitoring the serum free light chain assay, and once the serum free light chain assay normalized after 1 or 2 cycles, you put them on maintenance with the ACE inhibitors, or you made it sure that all of them received 6 cycles?
Ma'am, thank you. Ma'am, it depends upon the eligibility of the patient. First of all, when a patient is being diagnosed, we have to characterize him for the bone marrow transplantation, whether he's a low risk patient, intermediate risk patient, or a high risk patient. For a low risk patient, like less than 70 years, having no other end organ involvement, patient is having the NYHS scoring is just 1 to 2, tropty levels are very low, less than 0.02. So all of the factor which we consider the eligibility for the bone marrow transplantation, if it's a low risk, he can go for that. So we will consider 2 to 4 cycles. They will check the FLC ratio. Then we will push the patient, we will ask the patient for the bone marrow transplantation, especially with melphalan. And thereafter, after day 100 of the bone marrow transplantation, we'll check the difference between involved and uninvolved free light chain assay. If this difference is less than 40, means the patient is maintaining the remission. We will just follow him with the FLC ratio analysis. If it is more than 40, the difference between involved and uninvolved free light chain, then we have to give them some kind of consolidation therapy. Going to the intermediate risk patients, we offer the Cybod, and if daratumumab is available, that is a boon to it, because we get a very good response with daratumumab. If it is not there, we offer them Cybod. So the protocol of Cybod is like, because R is a government institute, patients are not very affording, ma'am. We generally do it after the 6 cycles. We give 6 cycles. But those who are affording, we can even do the free light chain assay before every cycle. It is said, like, if you want to check your response, like, it should be at least 50% decrease in the differential free light chain ratio.
Yeah.
But at least after 6 cycles, we have to check whether the difference between the
So
involved
yeah,
and
I got your
uninvolved.
point. So it was like 2 to 4 cycles you considered, and if patient attained remission before that, then you would switch to just the maintenance treatment.
No,
And
those who are on intermediate risk, we definitely give at least 6 cycle. We give for them.
Okay.
Yeah.
So actually, in our institute, we are not giving Cyborg. We have made our own protocol, and we are just giving bortezomib and dexamethasone. We have some 5 or 6 patients, but with good response, because we have seen a lot of infections with Cyborg, with cyclophosphamide in particular. So we just stuck to bortezomib and dexamethasone. And there is one question in the chat box which is asked, the person is asking about the sensitivity of the tests, SPEP and serum immune fixation electrophoresis and the serum free light chain assay. So it is the combination of the tests that gives more sensitivity, right? Not like you go for a combination of the tests rather than one particular test. And the urine protein electrophoresis is not, you consider it routinely for all the patients, or
No, ma'am. As I told during my slide, UPEP doesn't have sensitivity. If we want to do UPEP, we'll do on a 24-hour urinary sample. That has a sensitivity.
So you've been doing UPEP for all the patients?
No, it's basically, we generally do SPEP.
Okay.
With immunofixation.
Okay. Thank you.
Thank you.
Thank you so much. Over to the other chairpersons.
Swarnalata madam, do you have any comments?
Sonal is to speak. Yeah, so
Yeah.
yes, Sonal, please go ahead.
Especially when we have a bone marrow which is not giving us any clue. It is very like all the combination of all the tests is ultimately which will lead us to the diagnosis, and then the treatment, of course, would depend upon the patient's medical condition. Excellent case.
Thank you.
Yeah, I have one more question, madam. I think Arpita madam can answer this. So,
Yeah.
is there a role of, madam, the medium cutoff membranes in these patients, madam? Like if there's a high, free light chains, and then, did you try, or is there in literature with respect to medium cutoff?
No, we don't have median cutoff membranes, and the trials that are there, I was not very much impressed also by the outcome of the trials that were done in the overt multiple myeloma cases. So I didn't proceed for Shanlata because I have to make the government convinced that they should give us medium cutoff membranes too.
No, I think people are all coming, madam.
Yes,
All companies, particularly Baxter, it's all, I think it's available in 2,000 to 3,000, that medium cutoff membranes. So
yes,
I
ma'am,
was
it is coming, and he told
Yes.
me that you are using also in Nizams.
No, like he was behind me to use. I was wondering whether because we really can use. I was looking at literature. There are only 2 many studies, and that too with overt multiple myeloma, and
That
then
is overt multiple myeloma.
proven CAS nephropathy. And one of
And
the
these
studies
patients-
says because of probably the infection rate is very high because of loss of all these proteins. The infection rate is very high.
And Shonilata, their
Madam.
free light chain load is not that high also.
Yes.
Madam, can we end the case
Yeah.
discussion and move on to the panel discussion? Before that, may I request Dr. Anuradha Raman? She has raised hand. So, madam, any question from your end? Otherwise, we will go on to the panel discussion. because we have to finish the schedule.
I had just a little doubt, Manju.
Yes, madam.
Dr. Neeraj, you were telling something about involved and uninvolved FLC. I didn't
Yes, ma'am.
understand that. What did you mean by that?
Ma'am, as I said, no, we'll get a free light chain assay. So suppose on the biopsy, like the amyloidosis patient, we have most of them had lambda predominance, 13 out of 12. So when we done a SPEP with immunofixation and a free light chain assay, we get a number, the lambda and kappa. So we get a ratio, we find a ratio thereafter. So difference between the involved, suppose in the amyloidosis, we get 12 patients who are lambda. So amount of lambda minus kappa, involved versus non-involved.
Okay.
Yes, ma'am.
Thank
So,
you, Dr.
yeah, Please take over and proceed to panel discussions.
Panel discussion. So already the time is short. Without much ado, I would like to go to Silata ma'am first. When to suspect, ma'am, this entity? Who are the candidates whom you considered that you would go for extensive search in those patients? And what are the common kidney lesions also?
Okay. As Dr. Neeraj discussed in detail, it is a disease commonly seen in elderly males, and most of them may not have any constitutional symptoms because the tumor burden has not reached up to the cancer stage. So usually we suspect when they present with renal disease in the form of proteinuria, even nephrotic range proteinuria and microhematuria. So we do a biopsy, and from the biopsy, we identify the monoclonal deposition and proceed further. That is the usual method of the diagnosis in the clinical practice. It is also investigated when an elderly man presenting with an unexplained renal failure, classically like an acute interstitial nephritis due to some reasons related to this. And also the patient present, elderly male presenting with an unexplained acute pyelonephritis. On evaluation, detected severe renal failure, not improving in spite of infection under control. On investigation, goes to the diagnosis of some monoclonal gammopathies. And whenever we get a biopsy with the C3GN or MPGN with monoclonal immunoglobulin deposit, again, we investigate with other investigations as Dr. Neeraj discussed and land up with the diagnosis of MGRS. So extrarenal disease, whenever the patient has an extrarenal disease in the form of some vasculitis due to cryoglobulin or a cardiac disease, again, there is some suspicion of an extra or some other systemic disease accounting for the renal involvement, and investigate further in that line and land up with the diagnosis of monoclonal abnormalities. So these are some of the clinical situations where we suspect and we proceed further to investigate and diagnose MGRS. And the common renal lesions in MGRS, the most common being the AL amyloid, MIDD, PGN-MID, C3GN, and light chain proximal tubulopathy. These are the 5 common renal lesions associated with MGRS. And if you classify that into glomerular and tubular lesions, as we said, the most common glomerular lesions are the amyloid, and of which the AL amyloid is the most common with lambda predominance. And it can also be an AH amyloid or even an AHL amyloid. All these are organized deposits, and the other organized deposits in the glomeruli being this one, immunotactoid and cryoglobulins. These are the organized deposits due to MGRS, and MIDD, PGN-MID, etc. comes in the non-organized deposits, C3GN and even TMA. These are the other non-organized lesions, deposits leading to various manifestations in the kidney. And the tubular lesion associated, we know that the most common cause of Fanconi syndrome in an adult is a multiple myeloma. So it is proximal tubular, light chain proximal tubular, proximal tubulopathy, LCPT, that is presenting as Fanconi syndrome, is one of the tubular manifestation of MGRS. And it can also lead to some rare form of tubular disorders like crystal storing histiocytosis, which produces something called the pseudogochus cells, deposits within the phagolysosomes of the kidney, and it can be crystalline glomerulinemia. So there are various glomerular lesions as well as tubular lesions described, of which the most common being the glomerular lesion and AL amyloid as the most common entity. Thank you.
Thank you, ma'am. Thank you. I think another challenge is, madam, the coexistence of the comorbidities, which may give rise to the proteinuria or some
because
degree
it is a
of
disease
renal
of elderly.
dysfunction.
Most of them will have diabetes-related proteinuria also.
Yeah. So
Yeah.
that is one confusing point, that
Yes.
when you will take up the patient for actively for biopsy, that sometimes that pointers that we use to identify the non-diabetic kidney diseases.
Yes.
Thank you, ma'am. Narayan, next
Yeah.
time going to you.
Yeah, please,
So how to investigate the patient? You remember you asked me to present this in one ISN.
No.
When I
Ma'am,
stitched up the cases, yeah.
First of all, it is my pleasure to be part of this meeting. And this was an excellent presentation by Dr. Neeraj. So I would like to congratulate her. So this was very good flow of presentation. Coming to how to investigate these patients, and already has been pointed out by Madam Shwanlata and Dr. Neeraj also, she has pointed out, you approach go by first doing biopsy and then you go by. But sometimes it is different. What we do at our institute, when we have suspicion like it is possibly as now you have exposure of so many patients of this monoclonal gammopathy. So whenever you suspect like unexplained proteinuria is there, diabetes is not there, but even if diabetic patients, sometimes you suspect that in absence of retinopathy, in shorter duration of the diabetes, if the patient has unexplained proteinuria, patient has unexplained renal failure. So our residents have become very much focused on getting this SFLC. So serum-free light chain comes up first, and that is very cheap at our institution. It is not that costly like the private. So, and that gives us the first clue that whether the kappa lambda ratio is something abnormal, and then we go for. And we have very clear-cut demarcation of, we all understand by kappa lambda ratio by 0.26 to 1.65 for the normal healthy. And if renal dysfunction is there, then 0.35 to
3.7.
So that is the range. And whenever it falls, then we approach a reverse way. And this is the usual practice at our place. And definitely, once you do biopsy and something predominant comes, the deposition comes, and then you again also proceed other way around. So this, then definitely a situation comes when you have this report and suspicion, then you go for the serum electrophoresis, urine electrophoresis also. And actually, one question was there that I would like to point out about the sensitivity and specificity. When you have the serum electrophoresis alone, you have the sensitivity of the 70% and specificity is 80%. Urine electrophoresis has very low sensitivity of only 30%. That is, but specificity go up to 99%. This is the beauty of the urinary electrophoresis. If something comes positive and this specificity is 99%. So, and then sometimes confusion and low burden disease. This is already a low burden disease. Serum immune fixation is another way. So that we can go for. But although many of the investigations are not available in our part, but would have the laser dissection mass spectrometry kind of dissection. There are many newer way of getting this monoclonal antibody detection are there. Time of flight mass spectrometry kind of assays are coming up. And even in the free light chain assay, there are many different types of that free light assay. That is the one type that we used to do at our institute. But there are some nephelometric methods of this also. But nephelometric assay sensitivity is looking a little lesser than free light assay. Right. So usually,
Naren, one thing, that treatment is clone directed. So we actually try to get the clone. Once we get the plasma,
once you have this type of, sometimes the burden is so low when we go for the bone marrow examination, and the bone marrow, if suppose that is not fitting into a very low 2% or 4% of the plasma cells clones are coming, or even if sometimes not coming, and your kappa lambda chain is showing towards these lesions, then our hematologist determine the colonity of these cells. And as already pointed out, either by flow or if you have the fish, that extent you can go, and then you can try to come on the conclusion. What is the clone? This production of this which you have got on this is a clonal or this is a polychloride. Sometimes during the infections and some of the disease and autoimmune disease, you might have the automatic increased secretions or increased formations of these different kinds of this immunoglobulin chains. Even you can have the increased little bit kappa, lambda, everything. Even many times you can see depositions of the kappa, lambda, and in patients of the membranous nephropathy. So whether this is a clonal or not clonal. So that is determined to be the bone marrow biopsy and then going for the sleep, FIS assay or by flow cytography. So that we used to go to determine if this is clonal, then based on that clonality, your treatment is decided. So that is all our approach. Then today's time, what our hematologists have tried to do, they go for the low dose CT scan for the looking at the different other organs depositions and depending upon the situation, whether this is clear.
Narayan, most of the time we couldn't be able to find out any B cell clone. So most of our therapies are directed to the plasma cell clone, where we got the lambda deposition and some degree of amyloidosis. Most of the time we could treat the amyloidosis with plasma cell clone. And PGN-MID, which is likely to have a B cell clone, in those patients, we couldn't offer very effective therapy. This PGN-MID variety presented with very rapidly progressive renal failure, allowing us not allowing us to do a lot on quiescent stage. So they progressed to dialysis, they died, we couldn't help.
Definitely a treatment wise, then you have to decide how you are going to do. Like Maitri has pointed out, that is the same reasons here. Cyborg we don't use now. So most of the times it is the board. One of you have to go proteasome inhibitors. One is the immunomodulators, and either we can use with the dexamethasone or without dexamethasone. And daratumumab is now available in some of the patients who can afford. We can use this. So combination, usually cyclophosphamide-based regimens is not used at our place also. So either POD plus halido or lenalidomide and plus dexamethasone is the usual regimes. Only because of the fear of them, and definitely we can discuss in some of the patients who are eligible for autologous stem cell transplantation, then definitely your regime should be directed towards that rather than going towards getting this treatment or getting these remissions with the abilities of it.
So we will be more directed to achieve complete remission in those patients, because after attaining complete remission, stem cell transplant would do better. So with that, Radhika.
Yes, ma'am. Yes. Yes, good evening, dear all. Thank you. I'm honored and humbled to take this opportunity as moderator. Being fellow student of Dr. Swarnalata Gaurishankar Madam, I would like to ask Madam, would you like to elaborate the points in a biopsy report which should alert the nephrologist to a possibility of an MGRS even if the diagnosis does not state so?
Yeah.
Yes.
Okay. Thank you, Radhika, for that, and thank you all for the invitation. I won't take much time because I think I understand that all of you know much more nephropathology than the average pathologist. But I just thought for the students in this audience, when you are reading the report, please make sure that the kappa and lambda light chains are included in your immunofluorescence. Many people would try to cut cost and not do kappa and lambda. So please check kappa and lambda and look at whether there's a differential staining of those two mentioned in the report. In the glomeruli, diabetic nephropathy, as has been mentioned, is a very common finding because many of these patients are diabetic, and MIDD looks exactly like diabetes. And if your pathologist is not very very careful about the light chain interpretation, it might be passed off as a diabetic nephropathy. The clues itself is in the report. You will find that insudative lesions are not too prominent. Vessel changes of diabetes would be not there, like hyalinosis and all that. Okay, so that is something which you should look out for in your report. Cast nephropathy, it's not by definition an MGRS, but cast in light chain cast nephropathy need not always be PS negative, fractured, histiocytic reaction, and light chain restriction, because you can have a lot of THPs. In a little long-standing case, a lot of TAM hotspot proteins along with the light chains, and they may actually look granular, irregular. So if you have an elderly patient with unexplained renal failure, anemia, backache, whatever that you have said, and you find that in your report casts are very prominent, do ask your pathologist to repeat the light chains and also to do a paraffin IF. In our experience, paraffin IF for detecting casts seems much more sensitive than your usual IF. The last thing I would like to say is, in your report, if you have only complement and no immunoglobulins, again ask your pathologist to repeat the immunoglobulins to do a paraffin IF as well. Often these monoclonal immunoglobulins are better picked up on paraffin IF than on regular IF. And again, as mentioned, C3GN and TMA in the elderly, no, you will not be able to demonstrate the monoclonal protein in your biopsy, but it is a clue that you look for an underlying monoclonal and do all the investigations which Dr. Prasad has just mentioned. So thank you once again. And
ma'am, only one question from my side, madam. If you tell students about the utility of pronase digestion.
Okay, so just briefly about pronase digestion, your regular IF uses frozen sections. Okay, and the epitope that you look for when you do your FITC labeled antibodies may not always be exposed in your frozen sections. So to expose these epitopes, which are so-called hidden, you first take your formalin fixed section. You take your regular fixation tissue, which you have fixed in formalin and made the block. You cut sections. It's an elaborate procedure. It needs standardization and validation. You treat with enzyme pronase or proteinase K, and that will expose these antigens, be it the light chains, be it immunoglobulins, be it your heavy chains, light chains, whatever. And then on those sections, you do IF immunofluorescence exactly like you do on your frozen sections. I think there are some very good reviews available in literature. It's worth dealing with it. So that's the procedure for paraffin IF. So thank you.
One last question, madam. I mean, for this thing, yeah. So you told that paraffin IF. So when we are suspecting PG and MID light chain only, that is the new variant they added. So can you just elaborate on that, ma'am?
PG NMID light chain only. Yeah, actually, I have not seen any case at all. And I've read that in KI some time ago when it was published. You have a PG, just
Only
like in amyloid, you have only light chains. Rarely in PG NMID, you can have only light chains. Having said all this, the so-called, not often, but sometimes when you demonstrate a monoclonality, that say, for example, IgG kappa, and then people have done all sorts of tests on this by extracting the proteins, doing all sorts of things. They find that it is really not monoclonal at the end of it all. But I think for our understanding, we will say that if on IF you have a light chain restriction, we will assume it is monoclonal. So thank you.
Thank you. Yes, ma'am.
So, should we knock Manisha now?
Sure.
How to plan the kidney transplant in those who go to CKDG5, Manisha?
Okay, so first of all, I would like to congratulate Neeraj and Arpita. Excellent presentation. In fact, there seems to be no need for a panel discussion. She discussed the case so well and covered all the points. So basically, I would like to reiterate some points before I go to transplant. I'll just keep it very short. So there has been a paradigm shift in the management concept. Previously, all the books used to teach us that there is no need for chemotherapy because the tumor burden is low, and then we should concentrate more on renal preservation because most of the chemotherapy drugs are going to harm the kidney. So do not use. But that has been now completely rooted out. And now we go for clone-directed therapy, which has been very well discussed. And to find out the clone is very, very important. And Dr. Narayan also showed that you do Sept, IFE, as well as you look at FLC, all three. And as Arpita said, once you find the abnormal paraprotein, look for the clone which is producing it. So this is very, very clear. Clone-directed therapy is very important. So now, relation to the transplant, it's very important whether we go for the clone-directed therapy before the transplant or after transplant. That is question number one. The second question is whether we go for a transplant at all. Is it worthwhile? It is such a disease which might progress to frank cancer. So is transplant justified? So coming to the answer of the second question first, transplant is very justified, and in CKD stage 5D, renal transplant is not contraindicated. The survivals are very, very good. This is because now we have ample evidence to show that if you eradicate the clone prior to transplant, you can have a good post-transplant survival as well. So eradication of clone pre-transplant is recommended in most of the varieties of MGRS lesions, barring a few. They say in amyloidosis, you may do the chemotherapy post-transplant as well. So there is no hard and fast rule. The general dictum is try to eradicate the clone prior to transplant, especially C3GN and such diseases where recurrence is very high and very fast. Even in PGMID also, the recurrence occurs quite fast. So these diseases try to eradicate. If you are able to detect the clone, please try to eradicate prior to transplant. But again, individualize. That's the third point. Suppose you have a live related donor available. If the patient is otherwise okay, and if you have disease which does not have a very high recurrence, you can even plan for chemo post-transplant. But most of the centers, chemotherapy is done to eradicate the clone prior to transplant. And if the patient does not have any extrarenal manifestations, patient is a young patient, a stable patient, and in that case, what we should do is completely eliminate the clone. You do that by giving a clone-directed therapy followed by an autologous stem cell transplant. So optimize this. Before the transplant, be sure, take care of thromboprophylaxis, take care of extrarenal organ management also. If it is very severe, transplant is contraindicated. Take care of infection prophylaxis, vaccinate the individual, give clone-directed therapy. Very clear now that if it is a plasma cell clone, go for either cyclophosphamide, bortezomib, dexamethasone, and you have also heard about lenalidomide or thalidomide and daratumumab. These are the 5 drugs you need to remember when you are dealing with a plasma cell clone. If you are dealing with a B cell clone, which is rare and difficult to identify, the therapy should be rituximab-based therapy along with bendamustine or cyclophosphamide. So remember, PGs should remember these broad categories instead of trying to mug up different protocols. So you do this, and once you start the therapy, follow-up, hematological follow-up is important, and a renal follow-up is also important. Most of the patients will need 5 to 6 cycles. If you are not able to repeat the assays frequently, at least 6 cycles are what we generally aim for. Follow it up with the the autologous stem cell transplant, depending on the case. And then once this is done, the patient is completely cured of the clone, we can go ahead with the renal transplant. So this is the usual protocol followed, but as I said, individualize. You have a stable patient and probably an amyloid disease patient, and you have a living related donor ready to give. You can go ahead with the transplant and plan the chemo later on. Lastly, it should be multidisciplinary approach. The chemotherapy protocol is chosen by your oncologist most of the time, or the hemato-oncologist. And what is your role? We get referrals for dose modification, for renotoxicity. So we should know bortezomib does not need a dose modification. Cyclophosphamide, you have to modify the dose. So those things are in our domain, and we have to take care of this thing as well. So that's how you proceed. The last thing is transplant is not contraindicated. Appropriately remove the clone and go for transplant. So that's the dictum nowadays.
Thank you, Manisha. You endorsed what we follow in our institute also. Thank you. What Narayan was pointing out, and Mithri too, that whether we should think of eliminating cyclo or not, that we can take a decision on fixing the protocol. Thank you. I think, Radhika, if you have questions about, otherwise.
Yeah. One question to Swarnalata madam, that
Can we make this as a final question, please? Because we're already at 8:20 and we have another session and another panel discussion to go.
Yeah.
I think we can skip the question because
No, madam, no.
no,
Radhika,
because
please go ahead. No. Swarnalata madam, please.
Madam,
please.
rarely since you just
Radhika,
mentioned,
please go
madam.
ahead. Yes, please, Radhika.
Yes, is paraproteinemia workup is needed for every case of C3GN and TMA, madam?
Yes, ever since we heard Sanjeev Sethi talking about C3GN as a marker for an underlying paraproteinemia, in all your reports, at least as pathologists, we don't take the decision to investigate or not, but we do write a line in our report that this could be a manifestation of an underlying monoclonal paraproteinemia. And I don't think those investigations are so expensive. I think it's worth doing it because you correct that and you've corrected your C3GN. So I think it is indicated in the elderly meaning more than 50 years with C3GN, there is a need to investigate for an underlying paraproteinemia.
Thank you, ma'am. Thank you.
Thank you. Thank you very much, all of you.
Thank you, panelists and the moderators. That was an exciting, intellectually engaging and very dynamic discussion. Learned a lot from the insights shared by the panelists as well as the moderators. Now we'll move to the next topic, which is a presentation on interventional nephrology addressing access crisis. For this, I invite Dr. Saurabh Sadhukan, third-year postgraduate resident, IPGMR, Kolkata. For moderating this session, may I invite Dr. Shruti Chapiawala, consultant nephrologist and multi-organ transplant physician, Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. She is the Joint Secretary of WIN India and Honorary Secretary, ISN West Zone Chapter. Joining her will be Dr. Manjuri Sharma, Professor and Head, Department of Nephrology, Guwahati Medical College, Guwahati. We also have Dr. Anuradha K, Assistant Professor of Nephrology, Osmania General Hospital, as moderators of this session. Over to the moderators, and I request the moderator to kindly introduce the speaker. I think we can proceed with the session. Requesting Dr. Saurabh to present the topic.
Thank you, madam.
Yes, Saurabh, you can share your screen.
Saurabh, slideshow করে নাও।
Yes, madam. My slides are visible, madam?
Yeah.
Slide
Go for
Slides are
slideshow
visible,
mode.
but
slideshow mode.
We are in the usual.
Start the slideshow. There is an icon at the bottom of your screen.
Right end.
Saurabh, you know, na? The
Yeah,
lower
madam.
panel, the number 4 go to the lower panel. Underneath your slide. Saurabh, are you there?
Yes, madam.
Yeah. Click the fourth icon. Here you can see. Yeah, you have to click it. It will go to the slideshow mode.
Yes, madam.
And it is there on the top panel also, slideshow. You can just see, no, animation
Yeah.
slideshow.
It is
That
also there in
needs
the
to be
top panel slideshow. And you
You're
can go
able to
from
do
that, you
it.
can go to the presenter view.
Yeah. You're able to do it, otherwise leave it. You're able to see.
Yeah, or maybe
You
Siddharth
have
is
a
having the
technical,
presentation, so
yeah. This
Siddharth
is
can.
being shared by Saurav or Siddharth?
No, this is being shared by Saurav. Siddharth can take over and.
अगर उनका कंप्यूटर से हो रहा है तो दिक्कत होती है. Saurav, if you're not able to do, then leave it. It's not able to.
Okay, madam.
Saurabh, in the upper panel also slideshow is there.
If the slides are moving, he can start with his presentation.
Yeah, yes.
That's what, yes. Saurav, we can start. दिक्कत नहीं है, no problem.
Yes, madam.
Slides are
My
moving.
slides are moving?
नहीं.
No. Siddharth, you have the slides with you?
Hello, ma'am.
Yeah.
Yeah, now it's there. Now it's in the slideshow.
Now it's there. Carry on. Saurabh, carry on. I think now we will be able to
Yes, madam.
Move the slides.
But here the slides are not moving actually.
विपुल, आपके पास इनका प्रेजेंटेशन है क्या? विपुल
No,
जी,
ma'am. As of now, I'm not having it. If you
नहीं
can,
सिद्धार्थ के पास होने के लिए बोलिए. तो सिद्धार्थ नहीं है.
I'll call him, ma'am.
नहीं, सौरभ आपने सिद्धार्थ को दिए थे प्रेजेंटेशन.
Yeah, now it's moving.
Yeah.
It's moving.
Yeah,
Yes,
please
yes,
go ahead.
it's moving.
Go ahead. Go ahead. Yeah.
Good.
Go ahead, सौरभ. पहले से कर लो. हाँ.
Yeah.
Yeah, start from here.
Thank you. Good evening, my respected faculties and chairpersons. Today, my topic is about intervention approach and role in dialysis access management. So, I would like to discuss under the following headings of introduction to cases and analysis of our data of last 3 years in our institute and conclusion. So, as we all know that access crisis is actually state of dialysis in ESRD patients, and both central venous stenosis and secondary epiphyseal failure are common in this population, and estimated about 20% of all hospitalizations are due to any of the vascular access dysfunction, and they negatively impact the quality of hemodialysis as well as the quality of life of these patients. Thus is the morbidity and mortality of these patients. So coming to the first case of 51-year-old male, CKD5D, NKD was DKD, maintenance hemodialysis for around 2 and
Saurabh, the
3 years
slide
has
is
been
not
done.
moving.
Yeah.
So he had left brachiocephalic fistula for last 1 year and multiple temporary access and multiple episodes of CRBSI. So he presented to us with 3-month duration of left side.
He's left.
What happened?
He left. Actually, I think he clicked the
The wrong button.
Ma'am, Dr. Saurav was.
Abhi, he's there. He's there.
Okay.
He's there. Go ahead, Saurav. दिख रहे हैं, but you just go back to the case, ना? ठीक है, no problem. Go ahead with the presentation.
We suspected this case of central venous stenosis, and we proceeded with the diagnostic angiography followed by angioplasty. So this is the video of the diagnostic angiography was done, and we can see that there is a tight stricture at the left brachiocephalic vein just near the
Video is not moving,
junction
Shubham.
of the
Yeah. Now it's
SVC.
yeah.
Is it visible?
Yeah.
Yes.
Yeah, we can see.
Now we can see the steno segments. Yeah.
Yes. Then we did the balloon angioplasty. Here we can see that we passed a wire first, then the balloon of gradual dilatation from 8 to 12 mm. And here we can see that post angioplasty, we did the repeat angiography, and we see that there is no stenosis now, and the blood is flowing smoothly into the heart.
Do you have the post-angioplasty image, Dr.
So,
Sir? Okay, please proceed.
this is the most hard one. Yeah. So post angioplasty, the patient improved significantly. As we can see that post of day 5, the swelling had reduced, and there is the facial swelling had also reduced. And we did initiate the dialysis from left brachiocephalic fistula itself from after 1 week. So coming to the second case of 65-year-old male,
Put up your
CKD 5D
slides
on
and not
maintenance
moving again.
hemodialysis for last.
Change the slide.
Next, I'm moving now.
Yeah.
No.
Yeah, go ahead. Maybe the video will play and then the slide will come.
Yeah.
Go to the next slide.
So this 65-year-old male presented with secondary AV fistula failure for last 3 weeks. She had history of on maintenance hemodialysis for last around 3 years, and access was left radiocephalic fistula. And there was also history of primary AV fistula failure in right-sided radiocephalic fistula. So what we did do next? Next step, we did the clinical examination of the AV fistula and the venous segment, and then USG Doppler of both inflow and outflow of the AV fistula. Proceeded. Then we did diagnostic fistulography and plastic. So
The slide of the second
intervention.
patient hasn't come, Dr. Saurabh. The second patient's slide are yet to come. Could you just keep on moving forward with the slides? Yeah, next slide, please. Next slide. Yeah, next slide.
Slides are.
Yeah, next slide, please. Next slide. Next slide. Yeah.
Yes, Saurabh, go ahead.
Yeah, go ahead, Dr. Saurabh. Yeah, play the video. Play the video. Yeah. Yeah.
So this is the first image of the AV fistulography, and here you can see that only the is seen, but no venous segment is seen there because of the stricture and stenosis. So we did pass a wire first, that is Terumo wire, and we cannulated the venous segment of the AV fistula, and we passed the balloons, so gradual diameter of 4 to 6 mm first, and then next we did the post angioplasty angiography. Here you can see that now the both segment of the inflow and outflow, both the radial artery and the cephalic vein is seen now, and so
Network is poor. That's why he's getting logged off again and again.
Meanwhile, can we take questions? Shruti and Manjari, there are little questions posted in the QA box. Probably Girish and others can take the questions. Can we take the... yeah, Saurav has joined again. Yeah.
So this is the post fistulography angiography. You can see that both radial artery and the cephalic vein are now visible. And post fistuloplasty, the flow volume improved to 740 ml per minute, and we could start dialysis from day 5 to the AV fistula itself.
Yeah.
So different AV fistula complications are like from stenosis and thrombosis of the AV fistula. They can lead to various complications like chronic venous congestion, steel phenomena, inadequacy of dialysis, access failure, severe aneurysm dilatation, bleeding from prick site, and infection. So we in our institute we follow the simple algorithm that when a patient comes to our OPD with fistula related issue, we do brief history and clinical examination. Then we proceed for AV fistula Doppler followed by AV fistulography and plastic. Here we can see an image of radiocephalic fistula. Here you can see the multiple segment of stenosis here with the in the AV fistula site. So in our institute, we do the following examinations. First, the simple pulse and three-leg check, followed by pulse augmentation and arm elevation test. In case of like infostenosis, there will be feeble pulse and hyperpulsation or normal pulse will be there. In case of three, in infostenosis, the three will be discontinuous and the there will be higher pitch, louder, and then discontinuous in autostenosis. In pulse augmentation test, if there is infostenosis, the normal augmentation will not be there in infostenosis, and in autostenosis, there will be good augmentation of the pulse. In arm elevation test, there will be when we elevate the arm of the fistula, then there will be normal or accentuated collapse in infostenosis, and there will be no collapse in autostenosis. The most common site of radiocephalic fistula stenosis is the perianastomotic site, and in case of brachiocephalic fistula, more distant sites are involved near the cephalic arch and more the mid position of the arm. So coming to the our institute. To December 2000, declaration was in around 83.7%. Stent placement was done in 2 cases. We only did stent placement in the where there was the patient presented with restenosis within 3 months. Then only we did the stent placement. Otherwise, we do not prefer stent placement in the central venous cases. So the restenosis rate was around 24.3%, and time to develop restenosis mean time was around 156.3 days. So restenosis rate was around 3.6 per 100 patient months of follow-up. And mostly the patients, around 30 patients, mostly the patients have more than 3 years of dialysis vintage, and most common site of central intrajugular cancer. So more cases, more patients had around 53.5 patients had CRDS episodes more than 3, and they had multiple comorbidities. And the important factors, what we documented that many of the patients had improper tip position of the previous access, like palm cath. Most of the palm cath tip was in the SBC itself, not in the RA-SBC junction. And mostly they had dialysis vintage more number of temporary access, more number of CRBSI episodes, and more than one comorbidity. And the cases where we failed to recanalize had very late presentation from the symptom onset and high degree of toxicity and presence of multiple collaterals in the angiogram. Coming to adverse event, most common adverse event was a minor bleeding from the puncture site, that was 26%, and otherwise there was hematoma, and one case had stent migration to RA. So this is another case. Here you can see that the patient presented with severe right side swelling. Here you can see that there is a segment of right right subclavian vein stenosis from the angiography. Post, we did the cannulation to the first wire, then first the stiffer, then balloon, then the gradual dilatation. Here you can see that the gradual dilatation of the balloon. Next, post angiography, post central venoplasty angiography shows that now the blood is passing smoothly into the SBC. Coming to the data of AV fistuloplasty, total procedures performed in this time period was 77, and mean AVF patency was around 1.03 years. Successful recanalization was in 94% almost, and 5.2% cases were failed. The important factors that we noticed that in failure cases, there was presence of long segment narrowing with multiple collaterals, and the cases mostly presented in the AV fistula failure cases that there was history of improper evaluation by Doppler creation. Many of the cases had side-to-side anastomosis and deep venous communication, and the technique the technologists used to cannulate the AV fistula buttonhole rather than rope ladder technique. and mostly the CTV surgeons did not rule out any issue of presence of central venous stenosis pre-operative. Here we can see that another case of secondary fistula failure. This is the radial artery and radiocephalic fistula. Here I can see that there is a narrow cephalic vein, and this patient had presented to us almost 2 months after the fistula failed. And so we did cannulate the venous segment and gradually dilated. So post fistuloplasty, this was the cephalic vein, and now we cannot see the radial artery because the flow is now through the cephalic vein. So we did start the dialysis from 1 week later. So most commonly, we encountered the radiocephalic fistula as the secondary AV fistula failure cases. And most common type or site of the AV fistula failure was perianastomotic site stenosis, was mostly followed by outflow of venous site and followed by inflow stenosis. We did measure the fistula flow volume before angioplasty and post angioplasty. The mean AV fistula flow volume was around 70, and there was significant improvement of the post fistuloplasty fistula flow volume. The mean was around 540. So the adverse events of the AV fistuloplasty cases were minor bleeding mostly, followed by major bleeding, arterial thrombosis, and venous rupture was there. The pseudoaneurysm, when we did access the brachial through the brachial artery, then the access site had pseudoaneurysm in 2 cases. But the restenosis, which was most important factor for the central venous stenosis patients, the restenosis is not so common in AV fistula plus post AV fistuloplasty patients. Only 1.5 per 100 patient months of follow-up. So early detection is the key, and when we detect early, the outcome is good. But there are some limitations of these interventional procedures, that the consumables are very costly, and many of the centers don't have cath lab support, and restenosis is a factor for central venous stenosis patients. So we should work like a team comprising of the vascular surgeon, primary care physician, radiologist, and dialysis staff, dedicated coordinator, and nephrologist should be a team leader because he better understands the complexity of the dialysis procedure and better understands the importance of access patency and can coordinate with the dialysis personnel. In conclusion, central venoplasty and AV fistula angioplasty have very good outcome with minimal adverse events. It has the key role in dialysis access management, and early detection of the access dysfunction should be the priority. But future RCTs are needed for drug-coated balloon versus conventional balloon angioplasty, whether there are any role of long-term anticoagulation for restenosis prevention in case of central venous stenosis patients. Thank you.
Shurav, we must mention that we are very grateful to our interventional radiologist who helped out in our difficult days of journey, Dr. Mausam De.
We have learned from him only, Dr. Mausam De, who joined in 2021 from SGPGI. We all learned from him. For initial 2 to 3 months, we had very difficulty to do on our own. We took help from him, and for him only we have reached this place.
Thank you, Dr. Saurabh. Over to the moderators.
I think it was a very nice amalgamation of all the data, but yes, the cost remains prohibitive for patients to keep going for plasties. And sometimes we have seen, at least in our experience, that we do venograms, we do plasties. It costs more than doing a fistula. So sometimes patients prefer going for new fistulas rather than getting plasties done, given that it costs them a lot in the cath lab. Manjuri, Dr. Anuradha, what are your comments on this?
Dr. Shruti, Saurabh, that was a good presentation. We do also get fistulas, problem with the fistulas. Like how you have rightly mentioned, also how Dr. Shruti has rightly mentioned, the cost is a big burden. Working in a government hospital and the patients being from a very poor economic status, telling them about to go ahead with a venogram and a fistulography and a fistuloplasty is very, very expensive. At least in my center, it is not less than 50,000. And the videos what you're showing, yes, it looks very like after doing the after removing the stenosis by the fistuloplasty, the video is very good. But let me ask you one question. Instead of coming up to these complications, are there any preventive measures by which we can prevent this complication? This is a very dreaded complication for our patients, and they are usually they come with in a very painful status and they are very anxious. So can you tell about something about the preventive measures whereby we can prevent having thrombosis or stenosis in this vascular access?
Yeah, there was a question also about the use of anticoagulants. So is there any?
I think Padmini, we will proceed on to the panel discussion because the questions are very valid and all these things. So Jyoti Priya, over to you. Manjari, your question will be answered by the panelists as well as the questions that are posted in the QA box. Thanks, Manjari. Thanks, Shruti, and over to Jyoti Priya.
Thank you. And after those captivating cases and moderation, we'll proceed to the panel discussion centered around the same subject. So for moderating the session, I invite Dr. Manjusha Yadla, Secretary of WIN India, Professor and Head of Nephrology, Gandhi Medical College, Hyderabad. And joining her will be Dr. Padmini Kanago, Assistant Professor of Department of Nephrology, MGM Super Specialty Hospital, Indore. Over to the moderators. I request the moderators to introduce our panelists.
Thank you. Thank you, Jyoti Priya. And it's been wonderful listening to everybody over the last 1.5 years. So we shifted our guest already to the vascular access. I think next 20 minutes, probably we should not stand between dinner and the audience. But nevertheless, I think the panel discussion will try to make it interesting a little bit. So I take this opportunity to invite the elite panelists of today's panel discussion, Dr. Girish, who is joining us from Bangalore. He's consultant nephrologist from INU, Institute of Nephrology, Urology, Bangalore, and is also the one who spearheaded the introduction of 1-year training or fellowship program in interventional nephrology. I think he's going to speak to us on that as well, a single comment. Welcome, Dr. Girish. Along with him joining is Dr. Smriti Sinha from Delhi, who is a consultant nephrologist, Marango Asia Hospital, New Delhi. Along with them is Arish Inertial, all of them young nephrologists. So consultant nephrologist from Jaipur Golden Hospital, Rohini, New Delhi. And along with them is one of the mid-star little senior consultant nephrologist from Mumbai, that is Mayuri Trivedi, Professor and Head Nephrology, Lokamanya, I think LTMG Hospital, sorry, Mayuri from Mumbai. So I welcome everybody for this session. So without much ado, I will start shooting my questions, and also Padmi, who has joined me from Indore, sorry. So anyways, I think the first question is to you, Dr. Girish. I hope you're ready to go. In an LMIC setting like India, what are the challenges and limitations? As we have heard, I think it's an excellent presentation from IPGMER, wherein the boy ended saying the cost limitations and, the disposable limitations, the cath lab limitations, the expertise, human resources, infrastructure, equipment, all these things put together. In LMIC like India, what are the challenges and limitations, and how did you foresee and envision that this could happen in Indian perspective of bringing in 1-year interventional nephrology fellowship? Over to you, Girish.
Ma'am, it's very kind because I find all my teachers up there and, very, very senior elite nephrologists. The first thing, the best thing that could have happened to this country is WIN, because, women are mothers, and we need mothers to take care of this entire nephrology community. So the best thing that could have happened is WIN. Okay, so straight away going to your question, ma'am. I think the question of cost is a very, very valid question. So the answer for that is, the biggest challenge for interventional nephrology is the mindset. There is a preset mindset that this is a costly procedure, this is a costly affair. But with our experience of 1 year after starting ultrasound guided angioplasties, I have to tell you the cost of one intervention for an access is less than 10,000. If we have to be very, very precise, the cost of intervening in an access is 7,500 rupees if you do it ultrasound guided interventions, and you don't need any separate suits, you don't need anything extra. So in our department, we use a very, very small room, corner room for dialysis procedures as the angioplasty suite, and we have done 82 cases with 95% clinical success, that is able to dialyze a patient with 300 mils flow. So the cost is not at all an issue. We have to develop a team, and with ultrasound guided interventions, the cost is as good as creating a new fistula. That is number one. So coming to the barriers, the first thing is the mindset, madam. We have to have this mindset that if we have to provide a 360-degree care to our dialysis patients or our CKD population, this interventional nephrology is something very much part of the general nephrology. Then spreading the awareness to the all stakeholders in caregiving, whether it's a dialysis technician or the residents or the senior nephrologists themselves, that we should be aware that this is part and parcel of the nephrology program. And then as the journey has already started, imparting this training right from day one, like the residents in our institute, they are exposed to the access education right from day one. So they come and assist us in the interventional procedures right from day one. And what I have observed is they're really excellent. This generation is too good. So all that needs to change is the mindset. And then, of course, collaborating with the stakeholders like the policymakers. For example, if it's an autonomous institution, we have to work with the directors or the deans just to make them understand that this is very much essential. And also the Indian Society of Nephrology, I think Shyam Bansal sir is taking excellent initiatives that this should become part and parcel of our postgraduate education. The moment it becomes part and parcel of the postgraduate education, everything just moves forward, madam. So the biggest barrier I would say is just the mindset, and the consumables is no more a challenge because Indian companies are coming up, and it's definitely doable, madam. And then having a dedicated access coordinator, it is just that naming some person as an access coordinator makes a lot of difference. There was one excellent study from PGI that after they have started a vascular access coordinator, the results have been dramatically improving. So just that it can be a dialysis nurse, it can be a dialysis technician, just name them as a vascular access coordinator and just train them. I think the results will be much, much better. So I hope I have answered that question.
Excellent, excellent, Dr. Girish. I think whatever you have said is well taken into. And then Make in India, of course, Indian companies are available. Of course, the mindset, I think it's changing quite a lot. So all these things, the major hurdle will definitely be the cost. If it is made freely available or probably accessible and
Now even
cost effective.
Ayushman Bharat has all the packages for the access. So the Ayushman Bharat, which was released 1 year back, has all these packages. And with more and more nephrologists doing, I think the cost is definitely not a factor anymore.
You have made a good mention about the vascular access coordinator. So I think the KDIGO guidelines of 2019 do mention about having a vascular access team and a vascular access coordinator, which is in fact essential for all the nephrology teaching hospitals. Madam Arpita, madam, you want to add
Yeah,
something?
just one line to endorse what Girish said.
Yes, ma'am.
Excellent, Girish, analysis that I have only taken my director on my side. Myself, I was not trained in vascular access management, but I used to find patients who don't have a second fistula site, and they can even die if I don't make them alive for next 5-6 months. I can't go for transplant workup. So what I did with ultimate perseverance, I went to the director day 1, day 2, day 7, day 14. Sir, I need this. I need a separate USG machine. I need some consumables. And when it started moving, I am thankful to our state government too. It came from Shastro Shati Help that they supported the program, and one interventional radiologist was also employed to help us out. And it was an excellent journey where I was not the key role player, but I was enjoying the whole success of the team. And my students are doing well. Our interventional radiologist, who is very young, is stimulated and doing more and more interventions. I really enjoyed the journey.
Yeah, thanks, madam. Thanks. I think from interventional radiology, we should shift our gaze to interventional nephrology. That's what Girish is trying to do.
That
So
is why
what?
he is being trained.
Yes, madam.
Saurabh may lead now.
Yes, Girish, what's your opinion? How did you spearhead through the Indian Society of Nephrology to get that 1 year fellowship program on vascular access? A few sentences on this, yeah.
Yes, ma'am. Actually, my teacher from US was telling that, Girish, the guys who will be finishing this interventional nephrology will be much, much superior than us, because all the interventional nephrology so far in the country, we don't have a university accredited 1 year fellowship program. So this one is a proper university accredited program, which will go a long way in mitigating all the issues faced by the interventional nephrologists today. So it's a Rajiv Gandhi University accredited program. It helped that our director was the head of the new fellowship courses. So for the past 3 months, we have been visiting the university every day because it is just 20 minutes away from our hospital. So we have been visiting them and then getting them on page with what we are. And thankfully, we'll be starting before October 10th this year, and we'll be having an entrance exam with the intake of 2 students. So that's where. So the guys who are coming out of this fellowship program will not have any legal issues or anything because it's a university accredited fellowship program. So that's what we were trying to. And then one more point. Many of us were trying to understand the prevention of the central vein stenosis. The best way to prevent central vein stenosis is not to touch the central veins at all. Even when the patient comes requiring an emergency hemodialysis, all we can do is insert a femoral tunnel catheter. So if you use, so in our institute, what we do is we categorize any patient who comes to us requiring hemodialysis, whether he's a transplant candidate or not a transplant candidate. If the patient is not a transplant candidate, straight away go for a right femoral tunnel catheter with the exit site over the abdomen. It's excellent. It's as good as an IJV tunnel catheter. If the patient is a future transplant candidate, go for a left femoral tunnel catheter. So it will act as a bridge, and thereby you are not touching the central veins at all. So put a femoral tunnel catheter.
Sorry to disturb
Yes,
you,
ma'am.
Dr. Girish, but this
Yes.
is not as per the guidelines recommendation.
Ma'am,
There are some
no, ma'am. KDOKI 2019 guidelines, if you look into that, they clearly mention that if you are anticipating patient is going to get a permanent access in a short period of time, patient is a transplant candidate, they do recommend that it can be considered. Femoral tunnel catheter can be considered, and we have developed this program. So one of our resident has a project work on this, and what we have observed in 47 cases is they have acted excellently as a bridge to the permanent access, or they have acted as a bridge to the renal transplant. So altogether, the longevity can be increased by not touching them at all. So if at all you have to touch the central veins, then target wherever you're inserting a catheter, the target tip should end in the right atrium. Because as Dr. Saurav has shown, all these lesions were seen at the place where the tip of the catheter is ending. So choose the right length of the catheter. If you are doing it on the left side, obviously it has to reach the right atrium. So choose a longer catheter. If you're doing it on the right side, make sure that the catheter is ending at the right atrium, and also try to take a puncture closer to the clavicle so that you save that length. So the prevention of central vein lesions is number one. Don't touch them at all. You have the femoral tunnel catheter option in first place. If you are apprehensive about femoral tunnel catheter, choose a longer catheters and make sure that the catheter tip is ending in the right atrium. So these 2 strategies should be helpful, man.
Thanks, Dr. Girish. I think, ESKD Life Plan is one aspect which has been mentioned by the 2019 guidelines, wherein you customize the requirement of a particular vascular access according to the requirement of the patient, as has been said, whether the patient is having a long-term dialysis or transplant option. But definitely your approach is a little different, but definitely you have a justification what you're doing. Probably we may see that in guidelines. Agreeing with Padmini, yes, they have said the jugulars are preferred over the other veins, but that's what the probability of the patients who are going to be sustained on dialysis. So I'll come back to you, Girish, few more questions to you and also certain questions in the QA box. So before that, I request my co-host, Dr. Padmini, to take over and start shooting questions to Dr. Smith.
We were talking about these tunnel catheters, so I'd like to bring in Dr. Smriti, her opinion about the longevity and the sustainability of these catheters. And also, Dr. Girish mentioned that some of the government schemes are providing these catheters. So about the quality of catheters, does it have any significance? So over to you, Dr. Smriti.
Thank you so much. At the outset, thank you so much for inviting us. And I know Dr. Girish started with a very controversial statement about femoral catheters, but I will have to agree with Dr. Girish on this because I am also a very big fan of putting femoral TCCs. It's one of the easiest and least complicated methods of actually putting a catheter in. And I think the initial fear with femoral was primarily infection rates, which is seen more with temporary catheters. And if you put a femoral TCC, In fact, I have also done shorter catheters. Like if I have someone who needs to be bridged over to an AV fistula, and I know I need only 4 to 6 weeks, and I don't need a long, like a month kind of time period. We've even put like smaller catheters of 27 centimeters, which go only up till the IVC or maybe the end of common iliac, and it lasts really well. The infection rates are not too much, and you're really preserving the central veins, which helps in the long term morbidity, decreasing the morbidity of the patient, because central venous stenosis comes down by a large part. But again, like Sir said, it's a little controversial. First, do is you go with the IJ, and then second is you can go for a femoral route. Talking about the longevity of about the use of TCC, I feel that honestly TCCs are a big boon which has come to us recently. In terms of insertion of TCC, it is not a very difficult procedure, and this learning curve to learn how to put it is actually a very short one. If you have put IJs and temporary catheters, it's not really a very big deal to learn how to put a TCC. And a right IJ, again, this is controversial, can also be put without fluoroscopic assessment, with just the use of a simple ultrasound and your anatomical marker, especially in your naive patients in which it's the IJV has not been punctured. Ayushman and a lot of other government panels have now, they're giving you a decent package. I think Ayushman gives you about 35,000 or something for a catheter insertion. So even if you're going for a good quality catheter like a hemosplit from Bard or like a palindrome, these catheters cost around 16 to 20,000. To the hospital, it's even lesser. It's about 11 to 12,000 kind of thing. So if you're putting it even in a hospital kind of setting, it's more than easy to put this in a OT setting or a cath lab setting, or if you have an OT with with a C arm, you can even put it in these kind of settings, and it's quite cost effective because most of the packages, even in cash, is around 40,000. So you can actually put these catheters up front in patients who need it. So anyone who does not require an emergent dialysis, in the sense that they don't need to be in the ICU and need a dialysis in the next 6 hours, I feel planning a TCC also over the next 24 hours and then initiating a dialysis is a much better in a way to go about it, then go for a temporary catheter, then convert it, then do thing. TCC buys you time to decide whether the AV fistula needs to be planned or this thing of transplant needs to be planned. You get all that time. Talking about the quality of catheters, the most common catheters that are available with us are polyurethane or carbothane or silicone. Silicone has comparatively become less. Polyurethane is what is the most commonly used. And as per even the Kedoki's latest guidelines, depending on why you put in the catheter, if it is for a temporary reason, like you're bridging over for a fistula or for a PD catheter or for a transplant, then you remove it when you need to remove it. But in certain subset of patients where you have multiple AV axis failures, or the patient is an end-stage disease where you've decided that maybe he has a short life, maybe a year or less than a year, and TCC is going to be the ultimate axis, or his heart failure with ejection fraction less than 15%, then in those cases, there is no endpoint. If your catheter is working for 4 years, 5 years, go ahead, continue to use it. There is no recommendation on changing these catheters. So as long as you can maintain these catheters well, and you can, I think the maximum I have seen is about 4.5 years on one catheter without having to change it. And no, there were some dysfunctions, but it was treated with TPA and other things. But if you can pull it for as long as it works fine, I think there is no endpoint in the longevity per se. Though,
Dr.
yes, ma'am, sorry.
No, you can go ahead.
Yeah. So the only few complications with very long catheters, which is extremely rare, apart from your cardiovascular your catheter dysfunctions, thrombosis and all, is that sometimes very old catheters can start to have breaks and rupture and things like that, especially your external hubs, which can start showing breaks and stuff. So for that, I guess a lot of it is to do with how we are handling the catheter and the kind of materials we are using to clean it. So for polyurethane, at least, you cannot use alcohol or acetone to clean the catheters. You have to stick with chlorhexidine or maybe betadine. And I'm not sure about silicone per se because we primarily use these catheters. So avoiding using these can increase the life of it. Secondly, where they have been placed. So there have been cases where the internal part of the catheters can also break and dislodge into your venous system. So that's a very kind of difficult place to be in. And that most commonly happens depending on where the tip is. So sometimes if you've been overzealous and the tip is too into the RA, very close to the tricuspid, because of the constant shear of the blood flow, there can be a breakage of the tip of the catheter, which can also happen, and dislodgement of the tip. So again, placing the catheter right at the mid-atrium, not too above, not too below, to prevent the catheter breakage and CVC stenosis is something which is important. Secondly, when you put, we don't do it anymore, but initially subclavian vein was very commonly used, and especially your infraclavicular method of putting the catheter. In that, there is something known as a pinch-off syndrome, wherein the catheter gets pinched between the clavicle and your first rib. So because of that constant pressure on the clavicle, on the catheter also, there can be breakage of the catheters. So the way we inserted, where the tip is, how we handle the external hubs, and can really help with the longevity of the catheter.
Ma'am, you also raised a very valid point, maintenance of these catheters. And the most important issue in this is the point of care dialysis technicians. So how do we go about taking care of them and training them? Because we have some patients, and when they go to the peripheral units, they come back to us and say that in peripheral units, the dialysis technicians don't want to deal with catheters. They're more comfortable with fistulas. So would you highlight these points? How should we go about it?
So catheter-based infections is one, and of course malfunctions and thrombosis is the most common reason for us avoiding catheters in today's setting. The problem with dialysis technicians is that most of them don't have a uniform degree. Like some of them are just 6 months trained, some of them are 2 years trained, and again, most of them just train with the machine. They are not really taught the infectious protocols, why we use heparin, how much to put, what is the side effect, because they don't have that kind of background teaching. So education and training is the only thing I think which can help us with this. This needs to be a 2-point system. One is your own hospital. If you have a large dialysis unit, I think it really helps. Dr. Girish mentioned it, Dr. Manjusha also mentioned it, in investing in a good vascular access coordinator, having one person whose only job and responsibility is to take care of vascular access, also to train these. One of the points that they have to take care of is to train and audit the infection, catheter malfunction rates and all. So if you are one person who's looking over these dialysis technicians, telling them what they're doing right, what they're doing wrong, I think that will really be a game changer in decreasing the overall complication rates. And thirdly, I think we have started now with yearly CMEs for dialysis technicians also. I know there's one held in Delhi by Maulana Azad. Dr. Umesh Khanna does a regular dialysis technician training.
Yes.
So I feel that we should encourage our dialysis technicians to go ahead, participate in these kind of scenarios, because they also come back motivated to learn, to ask questions and all of that. So these two factors will really help with the dialysis training.
Just to add to that, there is Indian Dialysis Technologists Conference that happens annually every year in February. This happened in Delhi last year, and this is happening in Hyderabad this year. As you said, I think inclusivity of the nephrology should be there much more to enlighten them about these catheter infections. May I go ahead, Padmini, or you want to ask any questions?
No, ma'am, you go ahead.
Thanks. Yeah.
Thank
Now
you.
I shift my gaze to Dr. Mayuri. I think she's eager to answer my questions. She had recently talked about PD in this recently concluded conference. So Mayuri, over to you. What's your opinion about fistula first versus PD first policy? How far are we justified? Can it be applied in Indian perspective? Though a lot is being said about PD first in Hong Kong, countries like Hong Kong, etc. Fistula first is emphasized by KTGO. Over to you, Mayuri.
Good evening, everybody. So, ma'am, as you said about the fistula first initiative, though it came with a bang, now with the new KDOKI guidelines, we really need to rethink this whole concept of fistula first. And I would agree both with Smriti and Girish about the femoral perm cats, because that is what we have started practicing in our unit. So I work in a very high output tertiary government institute. And as we have a lot of schemes, including Ayushman Bharat and the local state schemes, which give up to 40,000 rupees for the vascular access. So we do not really need to think about a low quality perm cath or a low quality material that is coming, and we are using glide paths and barred catheters, and we are able to provide. So at least it is better to put a perm cath in these patients rather than them going out with a Joe cath, because our surgeon colleagues, there are nephrologists who make the fistulas themselves, but all of us are not trained. So at least these patients go out with a perm cath rather than going out with a Joe cath, to the tertiary centers, because most of us may not be able to provide the maintenance dialysis. Also, with the new KDOKI guidelines, the plan, the ESKD life plan, they are very clear that you cannot have a blanket rule for everybody, and it depends on the patient and his comorbidities and the phase of RRT that he is going to decide on in the long term, or maybe the age of the patient. The elderly patients will do well with a perm cath. So again, the AV fistula first initiative may not hold relevance in today, after the changing outlook towards vascular access as an issue on the whole. When you say about the PD, I'm a complete proponent of PD. I like PD. I have trained in a center with Dr. Arpita. She's my mentor. We used to do a lot of PDs for the simple reason that dialysis was not so commonly available, and that was a high output tertiary care public hospital. So we did get the government support, but most states are not covered with this. So I know that Andhra is, and Calcutta did have, West Bengal did have a lot of help from the government. But say for example, in Maharashtra, and from Bombay, we do not have that much of help. And PD, the cost, in my opinion, cost is the biggest issue that kind of makes it deterrent for patients to go. So usually PD in India is more of a patient who has multiple vascular access failures, and then his last kind of go-to thing is PD. But if we reach the stage of Hong Kong or Thailand where there's PD first, I'm sure I'll be happy, because I believe in PD as a modality, because I trained with PD as a modality.
Yeah, completely agree with you. I think the Prime Minister's National Dialysis Program also encourages the PD, but then to put it in a practical and end user perspective, I think we have a long way to go to make PD as the first policy. And as you said, we are privileged to be in Telugu states where, the government completely supports, whether it's perm cath, whether it is, any other catheter, whatever it is, everything is completely supplied free of cost. That added on to whatever is available in other states.
I would want to support what Girish said, is that, this whole concept that fistuloplasties and vascular access treatment is expensive does not hold true today, because you get a lot of government support. So I am in a public hospital, and we do about 130 to 150 CVOplasties with the help of the interventional radiologist in a year. So these are patients who do not have to pay anything. We have a lot of NGO support, plus we have the government schemes providing, the balloons. And obviously in India, the Indian jugaad is the reuse. So we do ETO the balloons and reuse them again. So I think we need to, it's what Girish rightly said, the mindset needs to change. It is not about the cost when it comes to the vascular access.
Yeah, you mentioned about KDOKI guidelines, ESKD life plan. So how do you think it is applicable to the Indian perspective? We cannot take it for granted. Okay, KDOKI has said this, because ours is a tropical country wherein it's a warm climate, is their infection rates are high, hygienic is a questionable one. So with the catheters in situ, I think some customization to our requirement needs to be done. So how do you think the guidelines can be little modified or customized to the Indian perspective?
Ma'am, again, the whole concept that a femoral catheter has a larger, incidence of infection and all, I am not again, because I am doing it, and I think that the femoral this thing, because it saves a lot of trouble, this. And again, I would reiterate that it is the vascular access coordinator who's your, who goes and kind of, repeats the same thing over and over again. And I would say that what we are doing is applying it to a lower middle income country like India, where we are making use of the schemes that are available. We are making use of the NGOs who are willing to help, and we are trying and customizing it that, at least from a tertiary care center, when a patient is shifted to a maintenance dialysis unit, we at least send them out with a perm cath and not with a Joe cath. So not with a temporary cath. So I think that would be probably some kind of an Indian jugaad to it. I hope we reach a level where peritoneal dialysis also comes to the same level, where we are able to make use of schemes and we are able to kind of offer this, because I'm sure the moment would probably start better in a public hospital, because there are no gains there for, and it would kind of popularize that. And with students passing out from centers, because I speak at a personal level that I became a proponent of PD is because my guide kind of did PD, and she taught me that you're supposed to offer and how are you supposed to do it, and that's how I became a PD, and I taught my students how to do it. So it's going to be like each one teach one, and PD is going to become something. So I think at some level, like ETOing the balloons, the fistula plastic balloons, all of this is us trying to kind of personalize it at our country, with the drawbacks of whatever our country has, especially financially.
Yeah,
Another
with the
aspect what I
permission of
want to add is, see, the guidelines say that you need to convert to permanent catheter within 2 weeks' time, even if you are, I mean, the non-tunneled, if you're using it, the guidelines say within 2 weeks is better that you convert it to a permanent catheter. So I think,
And
despite
we are
being in
talking
the
about permanent catheter first.
yeah.
And we
Yeah,
are
I
trying
mean, that's what
to
I'm saying. Even if we use a non-tunneled one, I think we convert to, because in government
absolutely.
hospitals, still patients come in emergency. It's not easy for us to put in a tunnel catheter
True, ma'am.
straight away. But at least within 2 weeks, we're able to convert because of the availability of the schemes and, disposables and all. Yeah, Girish, you want to add something? Yes.
Yes, ma'am. Actually, Dr. Smriti is also part of the guideline committee. We are working on Indian guidelines. So
Oh,
there has
excellent.
been an extensive work going on. Like we are trying to customize and we are trying to adapt those guidelines and add the Indian recommendations. So pretty soon we'll be out with the Indian vascular access guidelines for each and every aspect. So I
Excellent.
hope that should help.
Excellent. Looking forward to. So I think I will invite my co-host for the further questioning to the other panelist who's been waiting. Yeah. Over to Padmini.
Unmute yourself, Padmini. You are muted.
No, you are muted.
Yes,
Please
yes,
go.
yes.
Yes.
Yeah, one of the remarks that I'd like to make is that sometimes the patients are very comfortable with the tunneled catheters. They don't want to create a fistula. They become so comfortable with it. Anyways, that let me bring in, I take this opportunity to invite Dr. Arushi Nautiyal, and I would like to hear her comments about the failure rate of convincing our patients to have a permanent vascular access. And most of the time, especially in government sector, as Dr. Manjusha ma'am pointed out, most of the patients are crash landers. So what is her take on this? Ma'am, would like to hear from you.
Thank you. Thank you for inviting me to this talk today. And yes, it's very unfortunate that a lot of our patients come crash land straight, first time diagnosed with CKD stage 5, renal replacement therapy. Well, the important way to address that is to increase awareness in the community. Through whenever we have the World Kidney Day, more and more themes are for general population awareness, and that is important. Alongside that, we should also make it
What happened?
I think there is a connectivity issue with.
Yeah,
Dr.
meanwhile, I think, Girish, can you take this question? CRAT, catheter-related atrial thrombosis. Manjuri has already answered in the chat box, but then you are also interested in taking that question. CRAT, over to you.
Okay, ma'am. So CRAT is very much common when we have repeated episodes of CRBSA. So the best way to prevent CRAT is there has been one clinical trial that's been done wherein they have used once in a week thrombolytic therapy to decrease the burden of this CRAT. The other way is there is no consensus or no recommendation for anticoagulation, the duration of anticoagulation. But all conventional studies say that you have to anticoagulate the patient for at least 6 months for catheter-related atrial thrombus. Again, the most important thing is you have to do a central angiogram whenever a patient is having the CRAT. So by doing a central venous angiogram, you'll assess the burden of the thrombus, and sometimes you can just do catheter-directed thrombolysis, or you can do balloon-guided angioplasty to macerate the thrombus, and that's how. So prevention is the best aspect, and again, reiterating that the once the catheter tip is in the right atrium, the incidences of CRAT is also very, very less, because all these complications happen when the tip doesn't reach the right atrium. Whenever it is in the superior vena cava, that's when the thrombus starts and it propagates.
Yeah, one more question. I think Smriti or Girish, either of you can take this. This is the effectiveness of venous stents and central venous stenosis. I think Manjari has already answered what are available, but then what is the effectiveness of placement of these venous stents in CVS?
Okay.
Central venous stent. I think Mayuri, Smriti, Girish, any one of you can take this question. Yeah.
So the outcomes of venous stents, the longest venous stent has lasted 4 years, but these stents were recommended before the era of drug-coated balloons. Now with the drug-coated balloons available, now that has taken a backseat. So whenever you want to stent a patient, that's only when a drug-coated balloon also fails. So venous stents have been reserved for very, very specific cases, like if there is severe elastic recoil on the table, if there is a rupture of the venous segment during angioplasty, or if the patient is having a severe elastic recoil or recurrence of lesion within 1 month. Those are the cases where we consider venous stenting. And also when you have recanalized a chronically occluded vein. So in those situations, we stent the venous segments, but then we should be aware that these stents will be jailing the opposite venous system. Like if you have stented the left brachiocephalic system, you will be jailing the right brachiocephalic system. So that is one thing which we have to keep in mind. And in-stent stenosis is also very common, which has to be kept in mind. So there are very, very few indications for venous stenting.
And we need to
Yeah,
remember that
Mayuri,
probably this patient would be on antiplatelets for a lifetime after that. So that whole burden of an antiplatelet agent and the complications are something that we need to. So as Girish rightly said, with the balloon with the drug coated balloons, the specification, apart from the cost, we aren't even mentioning the cost because we just said that we're getting the help, but the dual antiplatelets or even single antiplatelets are something that the patient is going to be on for a lifetime, and then the complications of that.
Smriti, you want to put in your school of thought?
Ma'am, I would just agree with what Dr. Giri said. For us, the most common indication is basically if there's a strong recoil or if there's restenosis and there's a failure of the ballonoplasty that has happened. These are the only two indications we go for a stent. Otherwise, plasty is the way to go.
Yeah,
Girish, I just wanted to ask you for the CRAT, how much do you anticoagulate before removing the catheter? How long do you anticoagulate before removing it? So 48 hours, 72 hours, or it doesn't matter?
Ma'am, actually the best way going forward would be to thrombolize the clot. So treat this as a pulmonary arterial thrombus. So first, we have very, very safe thrombolytics available, like the 3rd generation thrombolytics. So first, to thrombolize the clot, the idea is to decrease the clot burden. And once you have done that, then you can anticoagulate so that it is more effective. So we have done one study, ma'am, and the results are excellent. So depending upon the volume of the thrombus, you can give either 10 units or 20 units of reticulase, and then anticoagulate them with just plain warfarin, 2 mg OD or BD, and then follow them up at the end of 1 month, 3 months, and 6 months, and the results will be much, much better.
So you don't feel it's necessary to remove the access each time there is a CRAT? If the vascular access is patent, you just let it be.
Yes, ma'am. The most important thing is to retain the access to the vein, because if you just do a knee-jerk reaction, then again we're going to lose it forever. So try to rescue the vein and then address the thrombus.
And sir, do you also look at follow-up ultrasound or echo images to see if the size of the thrombus is reduced?
Yes.
All of that.
Yeah,
So if
at the presentation we measure the thrombus, then at 1 month we measure the thrombus, and so we
that
do a
will
periodic.
be very similar like how we follow up a DVT case of the lower limb. Probably you just keep doing the Dopplers.
Absolutely.
Mayuri,
And
Smriti, I think I need to put a speed breaker at this point. So I think CRAT is just the whole thing that needs to be discussed. Over to you, Girish. Last question before I ask the closing question to all of you. One is regarding the you are the proponent of the femoral, long-term catheter. So do you think it's going to have an impact on the transplantations? You said already that right is not preferred for the prospective transplant, but overall, what's your opinion? When you're a proponent of that, we need to justify if it's a situation that the patient can land up in deceased donor transplant or something like that. Yes, Girish.
Yes, There are two ways of looking at the catheter, any pump cath. So in what situation you're trying to use it? If it's as a bridge, then definitely yes, try to get out the catheter as soon as possible, because within 4 to 6 weeks anyway you will have a permanent access, or patient is getting transplanted. But if it's the only vascular access as the last resort, then definitely it will not have anything. Again, the most important thing is to avoid the CRBSI episodes, because we have seen patients. I mean, the literature mentions the longest duration of a tunnel catheter is 18 years. Dr. Charmaine Lok, the longest catheter that has been kept in place was for 18 years. So the most important culprit is CRBSI episodes. If you can prevent CRBSI episodes, the longevity is definitely going to be there. But then if the patient is a transplant candidate, try to take it out as soon as possible, because all said and done, catheter is which we have to. Yes.
So if it's
Thank you.
outright a transplant candidate, I would still recommend go for an
Absolutely.
Yes.
Yes. Right. Right, Ajay Pamkar. Yeah.
Yeah. Okay. So, final question to you, because we are just nearing 6 more minutes for us to go before 9:30. Closing question to all the panelists out here. We are missing Arushi anyways. We think that vascular access is a multidisciplinary in approach, like saying that the surgeon, physician, everybody should be there. But then with the young gen, which is coming up like you, who want to manage the vascular access completely under your control. So do you think that it still needs a multidisciplinary, or how do you envision it to be only restricted to the nephrologist, that we are able to handle the complications, we're able to take care of the patient? I'm not speaking about the paraphernalia group of the supports, but then the other supportive groups, do we need them, or still we vote for a multidisciplinary approach? Over to you, Mayuri, followed by Girish and Smriti.
I would still vote for the multidisciplinary team to a very large extent, because we have obvious limitations as physicians, and we would probably be wasting time trying and imitating a surgeon. And we have obvious, and the other thing is, practically as physicians, there is a limited amount of time that we would be able to give to devote to this. And plus small surgical skills like taking sutures and all, you see a surgeon doing it and you see a physician, we are very, very primitive the way we do it. So I would still say that let everyone do their bit of the team. But at the same time, I don't think I would lower the importance of a nephrologist here, because at the end we are the consumer. When the patient comes with a failed vascular access, wo hamare sir pe aane wala hai. He's not going to go to the surgeon or this. So definitely we are a very large stakeholder there, but I would still vote for a multidisciplinary.
Yeah, I think Saurav rightly said, though this is a multidisciplinary, nephrologist should lead the team, it seems. So probably we see that the role of nephrologist is going to potentially increase, just not about 20-30%, probably to 50-60% in the future. As you said, it's multidisciplinary. Over to Girish and Smriti for this question answer. Yeah.
So I would also second that, but looking at the way like how Dr. Girish is now introducing interventional
exactly, yes.
People who are going to come out and maybe just want to do interventional nephrology hardcore, maybe they will have more time on that and more expertise and more so like especially like in a lot of places in Delhi they work in teams, so in that you might have one person who is just an interventional nephrologist. So maybe another 5-10 years things might change, but currently yes, of course, a multidisciplinary team is the way to go.
Girish, over to you. Your
Yes,
final
ma'am.
comments on the question.
I think the way to look at it is in academic institutions, definitely, as Dr. Smriti said, one of them can definitely take up this interventional nephrology. And again, the surgical skill sets, ma'am, maybe I'm putting something very radical here. Just want to bring it to your notice that the surgical skill sets of any doctor are at par once they start doing it repeatedly. For example, Dr. Vail Arvind sir does a skin-to-skin transplant.
Yeah, correct.
He
Absolutely.
does a transplant skin to skin, and he's teaching urologists today how to do a renal transplants.
Correct. Agreed.
So yes, ma'am. So at the end of the day, if it's an academic setup, definitely one of them can take up this interventional nephrology, because 100% it's a multidisciplinary approach. But the attitude of our colleagues definitely makes a bit of difference. Like if they know that there is a guy who does fistulas, they're going to be on their toes, saying that if we don't do, this guy is going to take and he's going to do the fistula. Number one. Number two is the rate of incidence of brachiocephalic fistulas has drastically come down the moment
yes.
nephrologists have started doing the BC
Definitely,
fistulas, because 90% of the complications are seen in proximal fistulas. So
Agree.
definitely, at least in academic institutions, nephrologists should do fistulas, at least in the initial years of their practice. Like, before I get very busy with my clinical practice, I have a lot of time. So why don't you spend that time in honing your skills and developing a good program? So definitely both can coexist. In academic institutions, interventional nephrology department can be there. In private institutions, it depends upon how they want to take, but both of them have a role, multidisciplinary and individual. Both of them have a role.
So, ma'am, it's
You have
in a
taken
nutshell, what Saurabh said is that nephrology needs to lead it.
Yes.
That's
Yeah,
about it. The
Saurav said
nephrology
that.
is center because we are the ones who
Yeah,
deals with
I mean,
patients.
what I mean is there's a paradigm shift in understanding what it was about 10 years back, what is going to be there in the next 10 years. I think there will be a revolutionary change in the handling of the vascular access. Of course, we are going to take the lead. Before I give the final comments at the closing, I think Dr. Arpita, who has in fact steered in the whole program, Madam, can I ask your final comments as we close the session? Madam, Dr. Arpita, you're here or have exited?
Ma'am,
Arpita, madam?
can I please put up my request in the
A short and sweet one, because yeah, please.
This
Yes.
will be very ultra short. So I'm happy to listen to all the youngsters who are taken up the intervention nephrology in a big way. And ours is one of the biggest department with very large number of transits happening. And we are happy to share that we are actually starting our intervention nephrology with a DSA lab facility coming up. Probably next another few weeks we'll having our own lab. But only problem
Congrats,
is
ma'am.
to have expertise. With the difficulty, we could only do few of the the intervention with the help of vascular surgeon and the cardiologist and intervention radiology. But of course, there's a lot of resistance from them. And I request, because I see a lot of experience with them in you, so I request all of you to please help us in developing our own intervention nephrology department.
Absolutely, madam. That's the need of the hour, ma'am. It's
Over
very,
to
very
Dr.
nice to
Arpita.
have that.
Dr.
Yeah.
Arpita, please.
Yeah, what
Yes, madam.
Shonalata said, every other discipline used to ask me, तुम cath lab लेके क्या करोगे?
Yeah, that was the
क्यों
first
cath
question
lab
anyone
चाहिए?
asked me.
Then when I sat in that meeting and told director that I need 2 days in cath lab, that is a common cath lab which is being used by everybody, even the neurology. So they put this question, why do you? I then put up a slide show that why I need a cath lab, and required lot of persistence and perseverance to get it through. The director somehow was on my side and did allow me to do it. Thanks to him. And what I should say as a teacher, that I find that there is a diversity in the students. Not all are meant for surgery, not all are meant for medicine. So depending on their personal choice and skill, they can move to which direction they prefer most. And as teacher, we should behave like umbrellas that could be a very inclusiveness. As I move a little up, I feel that as an administrator, as a department lead, what I need to do, I need to be more inclusive, more and more inclusive, more and more ramifying, more and more negotiating into interdisciplinary work. That I have learned. That is my small comment that I would share, that we should believe in the principle of inclusivity.
Absolutely, madam. Absolutely. Completely agree with you. That's what we are. We have the young gen who is there on the platform teaching us. It's the other way of teaching that we are learning today. So anyway, thank you so much. Before I wind up, my co-host, Dr. Padmini, final comment from you.
So I gather that mindset, perseverance, and just go for it. That is going to be the keywords. And I think, as Madam rightly pointed out, that it is not just individualization for the patient, but also for the nephrologist. With the number of nephrology seats increasing every year, I think we'll have more and more interventional nephrologists now. So those are my closing comments.
Thank you. Thank you so much. I think it's Arushi, we missed you. You want to say something?
Yeah,
finally we
my
have Arushi.
connection was
Yeah, I know,
off
bizarre.
my
You just
side,
want to
and
tell your experience in short and brief way, Arushi?
yes, ma'am, it was wonderful to hear this panel discussion. It brings forth the fact that we need to do a lot as nephrologists. not just with fistulas, with central vein catheters, but with peritoneal catheters, and perhaps even drafts in the coming years as they come up, and in plasties, and because eventually we are the caretakers of our patients and their accesses. And I'm very sorry to not being able to join in.
No worries, no worries. I think we should plan an extensive program on vascular access. So thank you so much. It's been lovely and lively listening to all of you and lots of learning from you. So the young generation, I do not know whether you're called Gen X or Gen Z or whatever it is. So I think there's a lot of learning that we have done today, and we look forward to learning from you continuously, as Girish has mentioned, Smriti has mentioned, and Mayuri has mentioned, and of course Arishi is doing a hell lot of good work. So thank you so much for joining us and enlightening us and empowering us. Thank you, everyone. The audience, over to Jyoti Priya for closing.
Yeah, that was a enriching and invigorating panel discussion. So with this, we had come to the end of the session, and we had a really insightful, wonderful case discussion, case series, and brilliant brainstorming panel discussion. So with this, we are concluding, and thank you, everyone. Looking forward to meeting you all in our next academic session. Thank you, everyone.
That is scheduled on 30th September with International Federation of Kidney Foundation. So we welcome everybody to join us. Thank you. Thank you so much. And good night. And thank you, Siddharth and Vipul. Thank you so much.
Thank you. Good night.
Thank you.
Good night. Good night.
Good night.